Hi, welcome to Neuro Day 3. I'm trying a new version of recording, so let me know if this works out better for you guys. I'm probably going to break the lecture up a little bit, record a segment and then stop and then record another segment so that the files aren't quite so big and not so long at one time. So if it stops abruptly in one place, don't worry, it'll pick back up. So today we're going to be talking about spinal cord injuries. So just like we did with head trauma, it's very prevalent in the U.S. So it's estimated that 12,000 Americans suffer spinal cord injury each year, and each year 259,000 people are living with spinal cord injury. The difference between the spinal cord injury and the head injury is the life expectancy. With head injury, we saw that there were many that were fatal, thousands per year that were fatal. With the spinal cord injury and the science that has been done to help correct some of the problems related with spinal cord injuries, people are living to a normal life expectancy. Typically, if there's premature death that wasn't initially related to the incident, it's because of respiratory function. So somebody who had a high cervical injury, somebody like Christopher Reeve, who had ventilator support for the rest of his life, that type of thing, usually it's because of some type of respiratory compromise. Either their own respiratory muscles give out or they're more susceptible to pneumonia or other infection. But they do still cause major problems. So it disrupts the person's life if they were previously up and walking normally and now they must use a wheelchair, or there's a major deficit to their gait or mobility, or they're not able to do the same job they did before. It can cause economic loss also, change in roles at home if they were the primary breadwinner and now can't be, or the primary caretaker of the children and now can't do some of the things due to their injury. Can definitely cause role giver strain, and the high cost of rehabilitation and long-term health care. Get here. So it's estimated the first year $682,000. So that's from the initial hospital costs from their injury, their trauma care, and any initial rehab that they have. And then subsequent years, over $100,000 a year to pay for rehab, to pay for special equipment, in lost wages also. So huge economic deficit here. However, many patients do still remain independent with some rehab and with some special equipment. There's vans that people can drive, or cars that will not only accommodate wheelchairs but also have maybe hand controls for paraplegic. Lots of different recreation equipment. Some of the wheelchairs will cost upwards of $20,000 or $30,000. Specialized chairs if the person is interested in sports or was an athlete before and wanted to continue as a wheelchair athlete, but it's very, very expensive. Also, people who need specialized chairs for quadriplegics or tetraplegics where they're controlled just with a straw, those are quite expensive, as well as ones that will go over different types of terrain. They make wheelchairs with treads similar to like bulldozers, but then again, you're looking at maybe $50,000 for a chair, which, if you think about it as being the person's only form of mobility, it doesn't seem so great, but initially outlaying that cost for a wheelchair, and then if they need to be replaced or repaired, just like your car would be, it's additional cost. So they estimate about 90% are discharged to home or another non-institutional residence, maybe with family or with a roommate, something like that, and then maybe 10% to nursing homes or long-term care facilities. So young adult males between 16 and 30 are at greatest risk, mostly because of the risk-taking behaviors and some poor decision-making within that age group. And it's estimated that 81% of all of them are related to males who are about in that 19-year-old category. So again, they've been driving now for a couple years out with their buddies, probably maybe doing a little underage drinking, diving accidents, motorsports. Think here, especially like out in the desert on their quads or on their motorcycles. Lots of injuries there as well. Skiing accidents, especially in the mountainous areas, account for a lot of spinal cord injuries. And of course, motor vehicle crashes are the number one. Followed by falls and violence. In certain areas, that violence number may outweigh the falls, somewhere like Oakland, California, some of those bigger urban areas, Chicago, those types of places, your violence may outdo your falls in this area. So just like we talked about with a head injury, there's the initial injury and a secondary injury. The initial injury is that impact to the cord, and we're going to look at some mechanisms of action in a little bit. But usually it's due to compression because of bone displacement, or the swelling decreases the blood supply to the cord. Rarely is it torn or transected because it is in that tough layers of dura, just like the brain is, but it can be penetrated by gunshot wounds or stabbings. So that primary injury, the initial injury to the cord, the secondary injury is that ongoing progressive damage that occurs afterwards, usually due to swelling and edema that's causing additional compression and decreased perfusion. There's lots of theories as to why that the initial injury causes so much damage. We're not going to get into this cellular level. Just know that, not everybody's agreed on exactly what happens and why it happens. So part of the problem from the initial injury is related to the apoptosis. This is a programmed cell death. So this is an autoimmune response when the body is injured and it sends, your T cells and your B cells up there and makes your blood vessels leaky, and it causes the swelling and edema. That programmed cell death goes through a cycle, and the phagocytes come and munch up those things. So your initial injury is that right at the area of injury. However, just like we talked about with the brain injuries, there is a bigger area of injured tissue, not just the point where the impact occurred, but because of that swelling, the area is both above and below the level of injury. This is just a pathophys map. It's good information to kind of wrap your mind around what happens when you have that hemorrhage or the edema, and your innate immune response coming in and trying to help. That autoimmune response actually can cause some additional damage after the initial injury. So because of that decreased perfusion, it results in hypoxia, obviously, because the blood flow is decreased. It can't carry the oxygen to all the cells. So you get a decreased partial pressure in your spinal cord, and it increases the needs of the lactate metabolites. So in most of the body, glucose is used as a primary energy source. However, in the brain and the spinal cord, your lactate is going to be your main energy source. So as the oxygen decreases and the blood flow decreases, so does the availability of that lactate to feed the spinal cord. So what we want to try to do is get these people stabilized early, get some steroids on board to decrease the swelling and edema, make sure that they are in traction if they need it, or in cervical or spinal alignment to decrease that secondary injury, because by about 24 hours, damage caused by that swelling and decreased perfusion is permanent. There's not much space for it to expand, just like we talked about in the brain injuries. The skull is hard and rigid, and so there's nowhere for the brain to go when there's extra volume in there. It's the same thing with the spinal cord. Because of those tough layers of dura, there's the bursa in between each vertebrae, so you can't really go out, and you can't really go up because you hit the brain, and you can't really go down because you hit the sacrum. So the ability for compliance in the spinal cord is actually even less than what we saw in the brain. So this damage occurs very rapidly and can be very diffuse. So the extent of the damage caused by the injury is compounded, both the initial injury plus that secondary injury. So immediate stabilization of these folks is really, really important. So the three main issues we're going to be looking at with spinal cord injuries, or three main sequelae, are the spinal shock, the neurogenic shock, and the autonomic dysreflexia. First, we're going to talk about spinal and neurogenic shock, and we'll get to the autonomic dysreflexia a little bit later in the lecture. So your spinal shock is typically seen for the first 24 hours up to maybe 7 or 8 days. And this is a temporary neurologic syndrome. This is not a circulatory collapse. It's really like a disorganization of the nervous system. So what happens is, below the level of injury, the patient loses motor function, sensation, and they have just flaccid paralysis. It's just like everything is just jelly. About half the people with a spinal cord injury experience this. So the biggest thing that you're going to see here is your loss of reflexes. It can start, like I said, as early as, an hour maybe after, and it can last 24 hours up to the 7 days. So you're going to definitely want to be checking your reflexes of your spinal cord patients when they come in, and continually as they're going through their treatment. This reverses on its own after the initial day to a week. So educating the patient that about spinal shock and the fact that some of it is going to be reversible. They can't make definitive diagnoses on long-term functioning until days after the initial injury. There's just too much swelling and other things going on for the doctors to make a good diagnosis at that point. So it's very devastating for a patient to come in and have nothing below the level of the injury. You don't want to give them false hope that, oh, it's just spinal shock and it's going to resolve. But you want to tell the person to remain hopeful and keep working with the doctors and keep working with the therapist, because some function may be returned. On the flip side, neurogenic shock is circulatory collapse. So this is a loss of vasomotor tone caused by the injury. And again, it's the spinal cord is disorganized and sending the wrong signals to the brain. So the pathways are all messed up. But this one is characterized by hypotension and bradycardia. So normally, if you had hypotension, you would have tachycardia in order to try and compensate. But in neurogenic shock, you're going to see both the hypotension and the bradycardia. And this is life-threatening. So when your patient, they start bottoming out and they look like they're going to pass out, set them up in the bed. Set them up to 45 degrees, then call the doctor. You're going to want to try to offset that, you're going to lay them flat for this one. I'm getting ahead of myself. You're going to put them down to try to increase the blood pressure. I'm getting myself mixed up with the autonomic dysreflexia. We're still in neurogenic shock, a little too fast. So hypotension, we're going to want to put them down. We want to try to increase that pressure. And you're going to end up giving them vasopressors, probably some vasopressin or norepinephrine, maybe some atropine for the bradycardia as well. So you definitely need to get the docs in there right away, because if this continues, obviously your patient is not going to come back. So immediate recognition of that hypotension is important. So classification of spinal cord injuries. It's going to be classified by the mechanism of injury, how they hit. We're going to look at that in just a minute. Is it a flexion or extension injury? The skeletal level of the injury. So what vertebrae is it? Is it a T10 fracture or a C4 injury? And then the neurologic level is going to be your functional level. What function, sensory or motor, do they still have below the level of that injury? And then the completeness or degree of that injury. We're going to see in a little bit that you may have a partial or a complete spinal cord injury. So your mechanisms of injury, your main ones: flexion, hyperextension, flexion rotation, extension rotation, and compression. Here's a picture that kind of goes along with these. So you're going to see your flexion in car accidents is probably going to be your most commonly seen injury. In some cases, you can have both a flexion and an extension injury. I think I told some of you guys that my grandfather died as a result of a car accident. So they were hit head on, and so he had the initial flexion injury where he hit the steering wheel, and then because he was tall and the headrests weren't adjusted appropriately, he then had an extension injury as his head went back over top of the seat back. So he actually broke C3, 4, and 5. So he was tetraplegic, didn't want to be on life support, and so he probably could have lived somewhat with ventilator support, but he didn't want to. So we chose at that point to turn off all of the machines, but just to illustrate that you can have more than one type of injury within the same event. Your hyperextension injuries with falls, you can see here, like hitting your head and that your neck is snapping backwards. Compression fractures, lots of diving accidents, anything head first. And then your rotational injuries are typically a combination of a flexion and rotation or extension rotation, such as falling off a horse or fall from like a high ladder, something like that. So level of injury, like I said, the skeletal level is the vertebral level. The neurologic level is the lowest segment where they have normal and both sensory and motor function. And typically this is going to be very close to the vertebral level. So it can be anywhere in the spinal cord, cervical, thoracic, or lumbar. So if paralysis of all four extremities occurs, it's quadriplegia, quad 4, got it, and tetraplegia if it also involves the cervical cord and the neck. So basically they don't have any head control either. These are the folks that you're going to see controlling their wheelchair, like with the little straw device where they still have movement of their tongue or they can blow air into it to make the wheelchair function. Paraplegia results in the thoracic or lumbar damage, where it's just the lower extremities that are mainly involved. So the picture of it. So like I said, you can have a complete or incomplete injury. Complete cord involvement results in total loss of sensory and motor function. So if it's a T12, middle of their chest, they have nothing, no sense of, no sensory input, so they don't feel pain, they don't feel touch, they don't feel temperature, and they have no motor control. An incomplete or a partial cord involvement can have some sensory function remain or some motor function remain. So you can have an incomplete quadriplegic. When I did my senior project when I was a recreation therapy major, I worked at a recreation center in Houston that was specifically designed for use by people with disabilities, and we had a quadriplegic wheelchair softball tournament. So these people all had either low cervical or high thoracic injuries that made them a quad. All four limbs were involved, but not all four limbs were completely paralyzed. They could still power their own wheelchairs. They were pretty amazing because they would, it was like full contact softball. And so if they hit the ball and they were pushing their chair to first base, they would try to knock the first baseman off the base in order to score or get on base. And they would take these horrendous tumbles in their chairs, and these guys could basically just like bench press themselves back up into a sitting position. So a lot can be done with therapy depending on the injury and depending on the person. Obviously, the younger the person is and the better shape that they were in before the incident, then the better outcomes they're probably going to have. So the degree of sensory motor loss depends on the level on the spinal cord where it happens and the specific nerve tracts that are damaged. When you have a cord injury, it doesn't have to affect the entire space of the spinal cord where the injury occurred, and we'll take a look at these in just a sec. So here you can see there's central cord syndrome, which is just that it affects that very center part of the cord. So when they have the initial injury, they may have spinal shock, they may have a lot of impairment, but as that spinal shock starts to resolve, you're going to find that the injury is really just focused on that central part of the cord. Then you have anterior cord syndrome, which is basically a dissection from front to back of the cord. The anterior cord syndrome is probably the most common. And then the Brown-Séquard syndrome we'll talk about in a minute, and that's a hemisection of the cord rather than front to back. It's right to left. So central cord syndrome, as the name would denote, damage to the central part of the cord. This is an incomplete injury. And this one is weird because you see more impairment in the upper limbs than the lower limbs. So you're going to see more impairment in the arms and hands, and to a lesser degree in the legs. So they may have sensory loss, they may have some bowel and bladder function impairment, and they may get sensations of like tingling or burning. When these folks see some recovery through their therapy, typically they're going to see the recovery first in the lower limbs because they're less affected, and then maybe some in the uppers. And again, the younger the person is when this happens, typically the better the prognosis for these folks. Anterior cord syndrome is probably your most common thing that you're going to see in your incomplete lesions. So this is usually a complete loss of muscle strength below the level of the injury because your descending motor fibers are in that anterior 2/3 of the cord. Sensory loss is usually retained. Sensory is usually retained because most of the sensory tracts are in the back of the cord. So even though they might not be able to move their legs, they can still sense the touch and the proprioception. However, they might lose some of like the pain and temperature sensations because those were a little bit more towards the front. There's little recovery with this one unless the recovery is seen in that first 24-hour period. And these are often a result of a flexion injury, like from your motor vehicle accidents, which are the most common, which is why you see this as one of the most common incomplete injuries. Then Brown-Séquard syndrome. This one is weird because it's that hemisection, like I said. And again, this is an incomplete injury. So on the same side that is injured, you're going to have paralysis and loss of proprioception. So they're not going to be able to move it. And if you move that limb, they're not going to know where that limb is in space. And on the opposite side of the injury, they're going to retain the movement of it, but they're going to lose the sensory stuff. So loss of pain and temperature and touch. So on the side that was damaged, they're going to lose the movement, and on the opposite side, they're going to lose the sensory stuff. So kind of an odd one, but an odd name too, so it makes it a little bit easier to remember. Posterior cord syndrome. This is pretty rare. You don't see it very often. Again, it's an incomplete injury. Here, they're going to keep the motor function and lose the proprioception. But this isn't one that you're going to see very often. All right, so your cauda equina syndrome is the next one. And this is actually a surgical emergency. So here you're going to find the person complaining of severe back and leg pain, kind of like if they were sitting in a saddle, the areas that would touch the saddle are going to be where they feel the pain. This usually happens due to a herniated disc or a tumor or a fracture right at the bottom of the lumbar section right before the sacrum. And this is where that huge bundle of nerves kind of comes out looking like the horse's tail, which is why they call it cauda equina. And it will result in immediate paralysis to the lower limbs and loss of bowel and bladder function. So if you have a person who had an injury, maybe a lumbar injury, and then they start complaining of this pain, you need to let the docs know right away because they can go in and surgically decompress this. And if they go in for surgery immediately, they can usually fully recover whatever motor function they had. But if they don't have surgery within the probably I'd say 4 to 6 hours window, then it's likely to become permanent. So here's a picture of where the injury would be on an MRI or a CT. Here you would see some type of herniation or disc rupture or something like that. You guys can check out the questions on your own. So the ASIA scale is basically the the patient is going to be seen by occupational therapy and physical therapy, and they're typically the ones that are going to grade the patient on this ASIA impairment scale. So this is how we usually classify the severity of the impairment resulting from the injury. And again, this isn't done until, a week out from the initial injury. Once the edema is resolved, the patient is stable enough to move around. Maybe a couple weeks after if they needed surgery or something like that. This is once the person can start participating in some therapies. So it's going to combine the assessment of the motor and the sensory function. And this is kind of what gives the overall determination of that neurologic level of injury that we talked about. So this is good for trending. People don't remain necessarily in the same ASIA scale for the rest of their life, or the same ASIA determination for the rest of their life. As they go through therapy and have rehabilitation, they may move up. So this is what the scale looks like. So A is bad and E is good. E is normal. And everywhere in between is some level of incompleteness. So you don't have to necessarily memorize these. Just know that if you see a spinal cord injury, a T10A, then it's a complete injury, and that person has nothing from T5 down. And then with the other ones in between, you'll be able to see maybe they keep some motor function or some sensory function. So I'm going to stop here for this first recording, and I'm going to come back to these clinical manifestations in the next portion.